know we have a mixed audience, so I was thinking as I was sitting there, how do I make what I'm going to tell you understand? You heard that we think that cancer in general is a genetic disease. And it doesn't mean those are the genes you form, it means there's something different in the cancer cells. So I want you to think, I was trying to think of an analogy. Think about a red Toyota coming off the assembly line as the DNA you're born with. And when we're faced with cancer, as cancer researchers, we have a car crash, a mangled up red Toyota at the end of the day. And we have to work backwards and try and figure out how it got from this shiny new red Toyota to this mangled car wreck at the end of its life. And one thing people talk about is the Toyota problem in cancer cells, which is the accelerator stuck down and the brakes don't work. Okay? And that's the basic inherent problem. So as we've worked back, trying to understand in cancer, since we think it's a genetic disease, genetics based in the genome, and we know the problem, it's accelerating too fast and can't stop, and we know what it looks like at the end. How do we try and understand what happens? Well, about 45 years ago now, I'm guessing, Dr. Kyle, the first speaker, started to look at patients in the Mayo Clinic who had an abnormal protein in their blood. It all looked the same. It meant it was coming from a clone of cells, which by definition is the beginning of a cancer. And he followed those patients for 4 decades. It's what we now call monoclonal gammopathy of undetermined significance. It means a funny-looking protein in the blood. And what he taught us along the way was that cancer is a multi-step process. It doesn't all happen at once. It happens over time, gradually, with one event following another. You've already heard from Dr. Kyle that myeloma is caused by plasma cells in the bone marrow. They're shown here. This is a primary myeloma, just to remind you where we're coming from. This is what they look like under the microscope. And they produce this protein that we can measure in the blood. You're going to hear about how we measure that later on. The reason people get sick, initially they don't get sick. Initially people have protein in the blood, nothing happens. Some of them die, most of them die of old age before they ever get malignancy. The reason we treat myeloma is because they develop one of these problems. We call them crab symptoms, or crabby sometimes, depending on how we're feeling, because they are high calcium, kidney failure, anemia, bone disease, and sometimes increased infection. And you've heard already from Dr. Kyle that we're making remarkable progress due to new drugs. Shown here in blue is the percentage of patients who would respond to treatment 10 years ago on the very far left of the slide. The T is thalidomide, 65% of people respond. The R is Revlimid or lenalidomide, which is a cousin of thalidomide, the drug we use in myeloma. And we have 90% of people responding. Dr. Kyle, do you want to answer me? Just kidding. And then V is Velcade. And you see that when we start to have Velcade and put it together with thalidomide and other drugs, we fully expect 90 to 100% of the people we treat now to respond. Not only that, they respond not in 3 or 4 or 5 months, they respond in 3 or 4 weeks. So we're making progress. I'll skip this because Dr. Kyle, well, I won't skip it. Let me tell you. Dr. Kyle showed this slide. The message from this is, for those of you who have myeloma or are friends with myeloma, is there are not just one type, unfortunately. You might wonder why we haven't cured cancer 50 years after the war on cancer was declared. So it turns out myeloma, which is a rare cancer, can be divided into 8 different types. And it turns out that those 8 different types have very different prognosis, which is the point of this slide. I'm going to get to the heart of this. Let me go back here. And it turns out, as Dr. Kyle also pointed out, the type of myeloma you have profoundly affects how long you're going to survive and how long you're going to do it. This is my Mayo Clinic, 150 patients who we consider to have low-risk disease, which for the good news is this is the majority of patients. Now, if we treat you today, and this is probably, we treated you in 2007, 2008, of the last 150 patients we treated, and we asked the question, how many are alive 5 years later? It was 80%. were alive 5 years later. So you might think that's not so great, it was 20% not doing well, but this is a disease which not so long ago had a 50% of people were not alive in 3 years. So we think that for this group of people, we're doing better. They're probably living about 10 years on average. But there's a group of patients, unfortunately, it's about 1 in 5 myeloma patients, that have genetic changes that are very difficult to treat. And it doesn't matter what treatment you give. It doesn't matter if you fly to Little Rock, Arkansas, or you go to Mexico to get hair, or you come here and get regular chemotherapy. It doesn't seem to make any difference. This is a very difficult disease to treat. And we wanted to understand what the difference between these two types of disease were. So here's what we did. We took 11 patients, and we asked the question, what changes over time in that patient? What are the other things that are happening to that car speeding along the road? So we took a diagnosis and a relapse sample, and we knew whether they were high or low risk, and we decided to look at the whole genome and try and figure this out. And it turned out when we look at the whole genome, we saw that what's shown on this graph is anything in red or blue means there was a change in the DNA of the cancer cell. And it turns out that if you have low-risk disease, even over many years, nothing changes. It's very stable genomically. Your drugs keep working, nothing bad happens. The car doesn't speed up any faster. But if you have that high-risk myeloma, all kinds of chaos is happening. It's accelerating all the time, it's becoming drug-resistant all the time. And that's what that slide shows you here, that with one exception, only the high-risk patients were extremely unstable. So that's lesson number 1. And we'll come back to what that means for you. So here's one patient, Mrs. Healy. She won't mind me telling you her name. She went on YouTube, you can find her. Mrs. Healy, who's had a bone marrow in the room? Anybody diagnosed it? No? Never had a bone marrow? Have you ever had one, Dr. Cal? I would never let him do a bone marrow. She went through about 6 of these things, bone marrow tests, and every time she did a bone marrow, she gave us a sample. And here's the course of her myeloma. So she has high-risk myeloma. She's passed, unfortunately. She had high-risk myeloma. Had a great response to Revlimid. It lasted 18 months. Had a bit of a response to carfilzomib, one of the new drugs we have. Then she had a little bit of a response to Velcade, and then things just get chaotic. This car is out of control. And every time she has a bone marrow, we change her treatment, we get a bone marrow, and she gives us a sample.